Hello, everyone. My name is Manea, and I'm an undergraduate from the University of South Carolina. This project is the culmination of my summer undergraduate research fellowship at Mayo Clinic and is an extension of our prior work in natural language processing for MR safety screening. We designed this algorithm to address a growing need in radiology. According to a study conducted by investigators at Johns Hopkins, around 700,000 new pacemakers are implanted each year, and 75% of these people will need MR imaging at some point in their lives. Electromagnetic interference can cause a variety of adverse effects, such as current induction and, in the worst cases, ventricular arrhythmias. The current safety screening consists of a questionnaire and interview with MR techs. This process is lengthy and depends on the patient's memory. Our goal is to build an algorithm to help with safety workflow and add yet another safety measure. To address this need, we have developed a rules-based natural language processing model using a list of curated terms derived from over 400 clinical reports of patients scheduled for outpatient neurological MRIs at Mayo Clinic in Rochester, Minnesota. The model could be deployed as a second screener to aid MR technologists in rapidly reviewing vast amounts of clinical documents. To build this algorithm, we used an open source library, spaCy, and the manual annotation tool Prodigy. The model consists of a pipeline that divides the clinical report into elements that can be searched and processed and includes sentence splitting and tokenization of words, identifying parts of speech, determining the relationship between words in a sentence, and comparing individual terms to pre-curated lists, as can be seen in Figure 1. Our original model was based on a list of search and exclude terms and context rules. Following annotation of 358 clinical reports using Prodigy, the model was tested to determine its efficacy. I found that the model had high specificity with moderate sensitivity of 74.17, as can be seen in Table 1. This was mainly due to the rearrangement of terms such as shunt, ventriculoperitoneal instead of ventriculoperitoneal shunt, misspelling of terms, and the use of specific brand names. Using the terms collected from the first dataset, I added over 25 search and exclude terms and 10 context rules. I then ran the algorithm again on the previously annotated dataset, and the sensitivity increased to 98.36, and the F-score was now at 0.94, as can be seen in Table 3. Model efficacy was tested on an evaluation set of 89 terms. The updated model performed slightly better than the original model, with an F-score of 0.84 compared to 0.8. However, both models still had false negatives due to the usage of an acronym and a brand name. Although the specificity did increase in the new model, the fact that the sensitivity remained the same demonstrates the limitations of rules-based models. Based on these results, I re-annotated the clinical records for named entity recognition and span categorization. Using the previously curated list combined with the new annotations, we plan to train a variety of base models, including the spaCy blank base model, bioclinical BERT, and a pre-trained clinical BERT on 4,000 Mayo Clinic records to determine whether they can achieve higher efficacy than the rules-based model that we have already refined. I would like to thank my research mentor, Dr. Daniel Blezik, and my colleagues from Mayo Center for Digital Health for guidance on this project, Mayo Clinic's Graduate School of Biomedical Sciences for their support through the Research Fellowship Program, and the American College of Radiology Quality and Safety Conference for giving me the opportunity to present my research here today.